Disaster Health Response Ecosystem webinar series. Today we'll have 3 guest speakers from Colorado. We're going to discuss how we evacuated 2 hospitals amidst Colorado's epic Marshall Fire, managing the chaos, being okay with being uncomfortable, and using relationships. Description, target audience webinar objectives are listed. Our accredited continuing education will be posted here and during the webinar chat, and then following the webinar, you should receive an email if you registered how to get your continuing education. This one is accredited for 1.5 hours. Our disclosure declaration. We only have one disclosure from Dr. Lawler. He's on the advisory board for Ignis Kinza and Stockholm Kinza. If you do have a question, please put it in the Q&A section of the Zoom. If you do have any kind of chat questions, we'll try to move them over to the Q&A. We do have someone who's monitoring the questions and answers in the chat box, but please use all the Q&A for any questions you may have. And we will have time allotted at the end of the webinar for questions and answers. To access your CME certificates, you have to log into the UNMC account. And I will post these activity codes in the chat as well. All right, today's guest speakers. The first one is Mark Doherty. He's a 10-year veteran of the North Metro Fire Rescue, where he currently serves as the Chief of Emergency Medical Services and has been a paramedic since 2007. Prior to North Metro, Mark was a paramedic at Denver Health, a firefighter paramedic in the city of Escondido, California, and a volunteer firefighter EMT at Rainbow Volunteer Fire Department in California. Mark also serves as an appointed member of the Mile High RETAC. He currently lives in Louisville, Colorado with his wife, Allison, and twin daughters. Our next guest speaker is going to be Michelle Deland, serves as the Executive Director at the North Central Regional Healthcare Coalition. Since joining the NCR in 2017, Michelle has led the development and sustainment of 600-member coalition, supported multiple regional planning initiatives, and facilitated the transition of the coalition from planning and preparedness to operational. Additionally, she served as a regional response coordinator for the COVID-19 pandemic. Michelle is a Colorado certified emergency manager, a FEMA master exercise practitioner, and has recently completed the National Emergency Response and Recovery Training Center's Infrastructure Protection Program. And we have Chris Millard. Chris is the emergency manager for Vista Adventist Hospital in Louisville, Colorado, and the safety officer and emergency manager at St. Anthony's North Hospital in Westminster, Colorado. He's been supporting hospitals in the Denver Metro with emergency management functions for 8 years. Chris is a retired firefighter, paramedic, and tactical paramedic from West Metro Fire Rescue in Lakewood, Colorado, and was an emergency planning analyst for the Department of Health and Human Services and the Department of Homeland Security. With that said, over to you.
All right, thank you, everyone. Screen share here. We unfortunately had a technical difficulty last time we were doing this, and our videos did not show as we would have liked them to, and they're pretty dramatic videos. So hopefully this time around it goes okay. As Mark introduced me, I'm Mark Doherty, the EMS Chief for North Metro Fire. I'll help kind of facilitate some of the conversation today. Unfortunately, Paul Johnson and Jason Rosa are not able to join us, so it'll be Chris, Michelle, and I going through this, and we'll do the best we can to fill in the gaps of what Paul and Jason's roles were. But I think hopefully you guys will get a good comprehension of what occurred and some of the challenges we faced, and then some of the successes that were pretty remarkable from just the relationships that we had developed prior to this event. So Chris or Michelle, do you want to jump in there at all?
No, not yet, Mark. Say we jump into it.
Sounds good. All right, so the Marshall Fire, if you didn't hear about it, it was in Boulder County, just outside of Boulder, just to the east of Boulder, and it was a pretty significant storm. It occurred on December 30th. We had winds that were gusting over 100 miles an hour, and it really could be considered a firestorm. The origin or points of origin were in more of a rural area of the county, and it quickly spread to two of our towns, two of our cities, and had a significant impact on a suburban area. And we'll talk about this a little bit, but none of us really anticipated this could occur. So pretty horrible impact for our communities, for the city of Louisville, the town of Superior. 6,219 acres burned, 1,094 structures. That includes a little over 1,000 single family residence homes. We lost an entire hotel during this, a Tesla dealership, and an entire strip mall. Of those, there's another 159 structures, $1 billion in loss. A significant amount of that was residential, and then $2 million in open space as well. I mean, if you've been to Boulder or the surrounding area, it's a pretty rural, kind of open, sprawling area with the city of Boulder and then a few communities sprinkled in there, but a lot of open space. Unfortunately, we did have 2 deaths, but it does sound like those 2 individuals decided not to leave. So of all of those that were willing to leave and that we were able to get out, it was a pretty remarkable evacuation process for the communities themselves, let alone the hospitals. And then that last line is Mountain View Fire. So Paul Johnson works for Mountain View Fire. In a single 12-hour period, they spent $20,000 in overtime in firefighter and EMS resources. So a pretty significant period of time. It occurred on December 30th, right around 11 a.m. And by the evening, essentially, most of the destruction had died down. So by about 11 o'clock that night. And we'll take you through where we were going into December 30th, and then what these 2 hospital evacuations looked like. So Avista being one of the hospitals and Good Samaritan being the second hospital. We'll also progress through some of the lessons learned that we garnered from a trial by fire, pun intended there. And I'll turn it over to Michelle to talk about what it was like leading up to this.
Yeah, thanks, Mark. Good morning, everybody. Again, Michelle Dealand with the North Central Region Healthcare Coalition. So while nobody expects to fight a firestorm in a suburban neighborhood, it is really unlikely that you're going to be doing that during a pandemic. And so we wanted to not only give you the firefighting, the behavior of the fire, and the impact on the hospitals from that event, give you that information, but also give you some context as to where we were as a region, as a state with regard to COVID, because that just complicated these efforts even further. So at this point in time, again, December 30th, we had come down from our Delta wave here in the state of Colorado, in the region, and we're about halfway up our Omicron surge. So we ended up as a region peaking at over 1,000 hospitalizations. We have about 28 acute care hospitals here in our 10 county region. So while we weren't at the peak yet of COVID for Omicron, we were in an extremely critical point with our availability and our staffing. So on the morning of this fire in our North Central region, we had 4% ICU beds available and only 2% of our medical surge beds available in the region. So those are some of the lowest numbers that we had seen and have seen since with regard to the COVID-19 pandemic. In addition, about a week after this occurred, the state activated crisis standards of care for EMS due to the critical staffing shortages that were being seen in the EMS community. And just prior to this, about a month before this, the state had activated crisis standards of care for healthcare staffing. So that gives you a little bit of a picture of how critical we were with regard to staffing, not just in the hospitals, but pre-hospital, post-acute care. The entire continuum, the entire system was extremely stressed already at the point of this fire. There was also some luck in that we didn't have a significant burn surge event out of this. There were about 6 patients that walked into a nearby community hospital, self-transport. 3 of those did have to be intubated, and all were transferred out to a larger facility. But we're going to really focus on the evacuation efforts here, which were remarkable. But we were fortunate that we didn't, in conjunction with this and concurrent to the evacuations, have a significant burn surge event. So again, just to reiterate, the stress the system was under at all different aspects when this fire broke out on the morning of the 30th.
Thanks, Michelle. And from the EMS staffing standpoint, I can certainly say that our folks on the front lines of responding to calls were at it's some form of a, kind of a crossroads where they were just done. The pandemic had been going on for 2 years, and then we had this significant impact on our community too. So we keep pretty much everybody in our thoughts of all of what impacted this, and the successes that actually were hopefully somewhat of a positive. And with that in mind, this is an image from the emergency department looking out towards the parking lot of Avista. And we'll show you a map here in just a second to kind of orient you to where we were. But we could not have done this without the collaborative effort and the selfless acts of everybody that was involved. There was a significant amount of the staffing that was in Avista, the ER nurses, the techs that actually had homes in the area. So thinking about them, thinking about the ED staff that supported this, everybody down to, even the janitors played some significant role in all of this. The EMS professionals that responded, in spite of their own safety in some incidences, the emergency managers, the EMS physicians, we'll talk about their role, hospital administration, the EOC, fire suppression resources that came to support the hospitals and protect our ingress and egress, North Central Region Healthcare Coalition leadership, specifically Michelle, and then our RETAC leadership that stepped up to assist us in providing more transport resources where they could. And so this is Paul Johnson's portion of the talk, and I'm going to do my best to fill in here. What Paul's role was the essentially one of the division commanders for the fire, and his fire department, Mountain View Fire Rescue, was in one area of this start of the fire. So they had a responsibility for the fire itself, as did Louisville. So what we're looking at here is in the upper left corner of this image is Boulder, the city of Boulder, a portion of CU Boulder South Campus there. And then we're looking back down towards Denver on Highway 36. The origin of the fire was somewhere, we believe, back in this area towards the west, and it progressed straight east in most areas here, and it somehow also jumped a little bit to the north. Every red home that you see image there is a home lost. The density doesn't do it justice when you're driving around the community, and you can see some of these areas of the utter destruction of entire neighborhoods. And then also the yellow ones represent any sort of damaged home. Like I said, there's a lot of open space here, but the density of these suburban areas becomes pretty significant very quickly. And I think a lot of that is what caught most of us off guard of. We can anticipate a fire in the mountains. We can anticipate a fire in the foothills, but a fire that starts in an open area and then goes through suburban Denver was pretty remarkable. To tighten in here a little bit, this is Avista Hospital down here. So this is Highway 36 going towards Denver to the bottom of the screen and going towards Boulder to the north. Avista is here. This is the Coal Creek neighborhood. We'll talk about that a little bit. And then this is a mental health facility adjacent to it. And the one thing I want to point out on this screen is the singular ingress and egress, the one way in, one way out road to the hospital itself and to this mental health facility. That played obviously added to some of our struggles that day. And as we zoom in a little bit further, we do this to help give everyone an idea of sort of the reality of, this isn't a building that you would typically evacuate. You're surrounded by open space, light flashy fuels as we would describe it, with grass, a lot of concrete, and 8-lane freeway. Just not something that as you look at it we would say initially, well, we have to evacuate that building. It's surrounded by trees, or it's got brush leading right up to it. This was a sort of a different day because of the wind, and we'll talk about that. But this is Avista Hospital here. Here's our ingress and egress point, and the emergency department right over here. And I'll turn it over to Chris to give an overview of Avista Hospital from the Centura system.
Yeah, thanks, Mark. So Avista is a level 3 trauma center. It's got a level 3 NICU as well. Like Mark said, we very defendable facility, very defendable location. Our HVA, our hazard vulnerability assessment, wildfire was, man, I want to say down in the high teens, low 20s. So again, looking at it from that risk standpoint, it just never was something that we really placed high on that list. The day of the fire, I was actually at St. Anthony's North and got a text message saying, here's a picture of the smoke. What do we do? So I drove out to Vista, and it was about a 15-20 minute drive for me to get out there. And from the time I actually arrived at Vista until we pulled the trigger to evacuate was about 15 to 20 minutes. So we really didn't have a lot of time to do much. In that 15 to 20 minutes, the first things we did was get a census of the hospital. Where were we at? We had 51 patients in-house. Immediately figured out we could discharge 21 of those. So that was done before the decision. That was just get rid of them, get them out of the hospital. We don't need them here right now. Let's just decompress. OR status, we only had 3 people in the OR. So we immediately started winding those down as best we could and moved them to PACU to recover. And that left us about 30 patients to actually move out of the facility. We then figured out what our resource needs were to start that process. And our first resource assessment was 3 critical care for 3 vented ICU patients, 8 ALS, and 3 BLS. That was our immediate resource request. That process is one of our significant after action items right now between ESF aid at the county level, the North Central Region Healthcare Coalition, EMS. How are we doing that is something we're going to talk an awful lot about. So yeah, that's one of the big things we'll definitely hit on.
Now, I want to point out this image here. That's actually, I think that's Chris standing there with the mask on and the towards the
that's
emergency room. Yeah, it's you. Yeah, emergency room door. But this is during the event itself. Somebody snapped this image, and if you just take a look at the floor, that's not just an unkempt hospital. That's ash that's coming through the door during the evacuation process. So we have a couple other images of the hospital itself, but this is on the eastern side of the building. Where you would, with the wind that's basically coming out of the west into the building. So this is on the complete other side of the building where you would not anticipate a large draft of smoke getting pushed in, but that's exactly what was happening. So at about this time, somewhere between 11 and 12, the fire had an origination point, and it had started to move very rapidly. Mountain View Fire Rescue in Louisville were doing the best they could to determine the risk to the community, determine where evacuation process needed to start. And this is an image I took on my way home from the office, trying to get to my own house. I live in Louisville, actually fairly close to the hospital there itself. So when this started, my wife called and said, "Hey, I think there's enough smoke that we probably should leave." And as it was talked about earlier, I'm from California, from a work background anyway, and I've had a pretty decent exposure to firestorms in the past. And it still, even at this moment, didn't click that it was just going to be smoke was going to be the problem. I did not see this being something that was going to burn down a suburban community. These are images taken from near the strip malls there, just to the west of the hospital. Lots of concrete, lots of asphalt, lots of grass, no leaves on trees, and bushes are on fire. So the community at the time, we'd received basically no snow up until December 30th. One of the first snows we got was actually that evening and into the next day. So everything was dry. The relative humidity was low. The winds were, again, gusting over 100 miles an hour, and embers were lighting bushes in asphalt parking lots, concrete parking lots, without really any actual push of flame length across into these communities or into these areas. So it was just embers falling into small bushes, which is a pretty remarkable situation to have to kind of come to grip with very quickly. And at this time, Chris had been talking to Paul Johnson about, we think we need to evacuate. And Paul, in his own admission, felt the same way I did. We both understood the hospital. We understood the layout, the type of building. It's a fire resistant building essentially. And there is no way that we could see the need for a hospital to evacuate that has that much defensible space. But as I turned onto this road here where these images were taken, the amount of smoke that was present, the impact on those that were trying to evacuate, and the inability to really move, to evacuate vehicles, to move people, was pretty substantial. So we're trying to take all of this in and understand that, well, it's not only just fire embers, movement of actual flame length, but it's the smoke that's going to be the biggest issue. And Chris, do you want to talk, just because PJ is not here, just a little bit about how that process worked between you and him and before I arrived there?
Yeah, I mean, it was originally, and we'll touch on comms here. Someone asked it in the question answer, so we'll touch on it here. A lot of our after action items are based on assumptions we had, and a lot of the assumptions kind of proved false during this day. We've always had it in our emergency operation plan and our annexes that, we always go through ESF8 through the Emergency Operations Center in the county. So on the radio scanner on my phone, that was my situational awareness for that day. We heard they were evacuating east of McCaslin Boulevard, north and south of Highway 36, which is basically where the hospital is. And that process, once we heard that, I immediately started making phone calls. My first phone call was to the Boulder County Dispatch. They didn't answer. They were completely overwhelmed. Then I called the Boulder County Emergency Operations Center. No answer there. We have 800 megahertz radios that I've got the Boulder EOC talk group on. Tried them on that and didn't get an answer there either. So basically, I didn't have any comms with any of the people that are in my plan to talk to and try and get information from and try and get resource requests. So the third person I'm pretty sure I called was Michelle and said, hey, I think we're doing this, I'm gonna need some help. And then she really started that process behind the scenes. Not really her role. I mean, it's definitely an ESF8 role. She did coordinate with ESF8 and she could talk to that a little more. But she kind of took on that role and actually started working with Mark a little more on ordering those resources. There was a lot of communications behind the scenes between Michelle, Mark, and PJ. And Michelle, even if she wants to talk about that, she can. But yeah, that once Mark arrived at the hospital, things started to actually happen. So Mark and Michelle, you can pick it up from there a little bit.
If I can just quickly speak to that conversation, only because we laugh about it now, but I think it exemplifies the trust, the relationships, the partnerships that we had built over the years leading up to this event, and how this played out. So the summary of the conversation was Chris called and said, I think we're going to have to evacuate. I said, okay, let me see if we can talk to our EMS leads and see what they're thinking. I ended up talking directly with PJ, who I didn't realize was out on the fire already. Talked to him, said Malyard wants to evacuate. He said, this is fully defensible. We're not evacuating a hospital. We got it. We're on scene. Okay, call Chris back. Chris says, I'm evacuating my hospital. There's too much smoke. We're moving patients out now. I called PJ back and said, PJ, too much smoke. I said, if you still don't want to evacuate, you got to call Chris back and tell him yourself. PJ said, I know Chris. I know his background. I understand how he operates. We've met before. We've planned. We've exercised together. If he says we have to do this, we're going to go ahead and do it. What do we need? So again, it was a bit of back and forth, but what it came down to was Chris in the facility, seeing the impact on the patients, on the staff, on the location itself, and saying, this is the call we need to make. And PJ saying, understood, what can we do to help? And then really supporting that response moving forward.
And to touch on, I just saw this in the Q&A, and I think it's actually a good point to bring it up. There was clearly an ICS structure, an incident command structure that had been developed for the fire itself. So PJ was a component of that. He was one of the division supervisors for the area that included the hospital. And when he was receiving this information, he's obviously still essentially, in charge of that area and understanding it. But moving that hospital on its own is, as you guys can imagine, essentially a Herculean task in the middle of a wildfire and a pandemic. So it deserved its own component of the ICS structure. And to do that, one of the lessons learned we actually will talk about here, though, was isolating the hospital and developing a command for that from the EMS side. So when I arrived at the hospital, I had just talked to PJ. We had the same conversation. No way we're evacuating this thing. It doesn't make any sense. I pulled up to the hospital. I could barely get my car door open. Is trying to get an N95 on, not for COVID, but to protect myself from the amount of smoke that was coming into my vehicle itself before I could even get out of it. So it was instantaneously clear, seeing Malyard trying to get over to my car to talk, that this was not something that we could just stay and see how it goes, that the hospital needed to be evacuated now. And I'll let Chris, if you want to talk about the actions for air handlers and what you guys had already tried to do mitigation wise, and it just wasn't working.
Yeah, so touch on one of the questions in the Q&A as well. So immediately once they started seeing the smoke and the smoke started kind of approaching the hospital, one other quick thing, when I left St. Anthony's North, which is 15 miles as the crow flies, at least from where the fire started, we were getting ash and soot at this hospital as well. So the distance this was already traveling was substantial. They had already shut down the air handlers at Avista, which in a hospital is not necessarily a good thing, especially your IT rooms are all, need that air conditioning, need that cooling. And once we shut those down, we were afraid we were going to start losing our phone systems, our Epic, our EMR, and other problems were going to start arising because of that HVAC shutdown. The HVAC shutdown helped a little bit with some smoke, but we actually had maybe 2 weeks prior to this another event where we had close to 100-mile-an-hour straight line winds. And during that storm, one of our COVID units, filter units outside, actually kind of picked up and smashed against the window, broke the window out and bent the window frame. And in that room is where we were getting a lot of smoke inundation and actually soot inundation in that room as well, which, learning about the hotel burning down and how they think that burned down after the fact, looking post-mortem at that, it was a little spooky that we actually could have had an internal structure fire based on stuff coming into the building. So HVAC units were shut down, and we didn't have any comm issues inside the hospital. Phones never went down. Other than that, the lack of utilities, air handlers was turning into an issue as well. So that just kind of was another thing of why we needed to evacuate.
One of the very fortunate things that occurred prior to this was 6 months prior, Chris Malyard had developed just a quick drill for our regional EMS communities to come to his hospital, to St. Anthony's North, and to at least do a tabletop discussion of how would we help with a surge at a hospital. And the idea was, there's an active shooter across the street at a movie theater. Lots of patients have presented to the hospital, and how are we going to integrate with EMS to move all of these sick patients to trauma centers other than our, that same hospital, so outside of St. Anthony's North. And in doing so, we had discussed the idea of an EMS liaison or EMS command. And this idea came from the Vegas shooting of, you need somebody at the hospitals to help be that voice on the other side of the radio. So certainly there's administration conversation going on inside of the hospital, EOC stand up inside of the hospital. Then there's a fire EOC for this particular event that's been stood up, and an incident command structure outside. But how are those two communicating? Who's the person that's the go-between? And that day, it just so happened to be me. When I pulled up to the hospital there, it became very clear that we had to evacuate. And at that point, it was, okay, let's identify what we need to do and come up with some sort of prioritized game plan to get these people out of the hospital as quickly as possible. One of the first things that I recognized, though, in talking to Chris, was he had gone through the appropriate normal steps to request resources. And Chris, can you repeat those again? What was it, the bus request? Ambulance request?
3 critical care, 8 ALS, and I think it was 3 BLS.
and some of those being oriented for NICU as well. There was, I think, 4 or 5 NICU patients in the hospital, and so I'm hearing that we have about 30 patients that we need to transport. I'm hearing that there's been a request for these resources, but there's no closed loop there. Chris had not heard back that these are the ambulances that are coming to you. These are the companies. These are the ETAs. They're coming this route, and they're going to be on this radio channel. We didn't have any of that. And just identifying the situation, understanding how we needed to prioritize more quickly getting out of the hospital, became clear that I needed to utilize some other method of doing that. And we just so happened to border by county line right out of Vista. So North Metro Fire, where I work, has the 2 communities to the east of Boulder, essentially, of Louisville and Superior, where all this was taking place. And because of that, we had our own dispatch center. We actually have 2 dispatch centers that function for us. So I went through that process like I normally would if we were in my city, and requested resources. And fortunately, just based on how the ring downs work from Boulder County, the resources in my county were not used yet. They were still available, and we were able to start sending at least a few medic units. We term medic units for fire-based EMS units and ambulances to the hospital. And that happened fairly quickly. I think within the first 10 minutes after the request, we had 1 medic unit arrive and take 3 NICU patients. You have anything to add there, Chris, about how that initially worked?
No, I mean, again, that was probably one of our biggest lessons learned, is around this resource request process. And again, one of the assumptions we had was, yeah, ESF8 will be there to take these requests, but because of the rapidly unfolding nature of this incident, the EOC was not stood up yet. So that assumption that, yeah, we're going to get these, is going to work. And again, a lot of the assumptions we had, and with a hospital evacuation, where the hospital was the problem, was it a structure fire, was it a flood, was it a hazmat spill, whatever it was. So maybe the resources would be there. We might be more tightly intertwined with incident command as opposed to emergency management. So that a lot of the assumptions have kind of changed. One of the things in the chat question answer, yes, we are definitely changing. I mean, at least I'm changing a lot of my processes around comms. Something we're calling the first 180, where we know we're not going to get that EOC ESF8 support for that first 3 hours of an incident, of a rapidly unfolding incident. So how do we make that work better? And that's where this EMS liaison came in, and doing it for real kind of really demonstrated how well it works. And we've got a whole process around that we're building.
And just to close the ICS component there, the weird thing that we did with ICS is we developed what we call the Vista command, and just stood up an isolated command from the EMS and fire side at the hospital to integrate with the ICS structure that was going on with the fire. And in retrospect, that was probably not perfect. Should have been named something else, maybe an operational group. But at the time, on a separate radio channel with all of the workings that needed to occur for it, that's what we decided to do. And it actually seemed to be feasible at the time. Just jumping ahead here. Chris, back to you to talk about how you made the decisions of who was going and where.
So yeah, our initial order of battle here was NICU babies were going first, basically just because of the amount of smoke in the facility, and just needing to get them out as soon as we could. The second were, I'm pretty sure ICU was planning to go second. Mom baby, Vista's a large mom baby. We have, I think, 30 some odd LDRP, labor delivery recovery rooms. We had a lot of mom babies in there. A lot of them were the ones that were discharged. So they were going third, then med surg would be fourth, and our PACU patients, or our OR patients, recovered in the PACU for as long as we could recover them. They were the last ones to leave, either by EMS or by family member. So that was kind of the internal triage process. We didn't do a lot of, typical either red, yellow, green, or any other type of triage. It was strictly based on units that changed a little bit based on which resource showed up. So we were fortunate enough, we never did get critical care ambulances. Not a single critical care resource showed up to transport patients. North Metro Fire, with who Mark works for, and Thornton Fire have transport ventilators, and that was extremely useful to move our vented ICU patients. We did have one close call with a patient we had to DC a Levofed drip on to move her to evacuate her. Communication between us and receiving facilities, we'll talk a little more about that, wasn't the greatest. And when that patient arrived in the ED at the receiving facility, they had no idea what this patient was on, and her pressure dropped pretty low. So basically, it was a good outcome with her, but it could have been a bad outcome based on some things. So when we look at the triage piece, it's not just triaging our patients, but triaging our staff to go with the patients that EMS can't take. So if we're not getting those critical care resources, we have to send our critical care nurses with the EMS crews to take care of those patients. And we just didn't think that far ahead in that process with at least one of those patients. So twofold in that triage idea. Destinations and transfers, we moved most of the patients, so 25 of the 30, we moved to St. Anthony North Hospital, which is my other facility, mostly because it really was the closest hospital within our Centura system. And another one of those assumptions, we always assumed it was going to be easy to move our patients within our own system, keep them in our own EMR, so on and so on. Not true at all. Within our EMR and the Epic and licensure things, we had a very difficult time moving patients within the EMR. We didn't have physicians that were able to write discharge and readmit orders, and the nurses could not physically discharge them in Epic. They just didn't have time to do that. So when they arrived at the receiving facility, the staff had no idea who they were getting. We just didn't have the resources at the time to do that. So that's one of our after actions, is trying to work with Epic and build some disaster resilient tools into it to circumvent some of these problems that we came up with. Whether that happens or not, we'll find out. We did overload St. Anthony North. Their immediate availability was they could take 2 NICU babies. Mark said the first ambulance to leave had 3 NICU babies on it. So that first one, we overloaded them. They ended up getting many more NICU babies. The team on the St. Anthony North side had to build more double bunk rooms in the NICU, and we had to convert our OB triage area into a NICU overflow. So that was all done on the fly at St. Anthony's North, which was a pretty remarkable feat in and of itself. Probably all I got for right now. And I know if you just look at the picture here, this is where Mark and I were standing in the ambulance bay, and the amount of soot coming in. Those sliding glass doors were a serious pain. It was a struggle standing right there with the wind and everything coming in.
If I could jump in quickly, kind of to talk, because we've talked a lot about that first 180 and the lack of situational awareness, and that the EOC within the city and county of Boulder was not yet operational. That doesn't mean that we didn't just go around or forget about that process. As Chris mentioned, he did call into ESF8. He did receive a call back. When I spoke with Mark after he did that initial resource request to determine from him what additional medical transport units he would need to support this evacuation, an HCC, at least not in Colorado, we don't have any authority. So while we can serve as a support function during a response, and we can operationalize to support our partners, we don't have the authority to call and direct ambulances to a scene or deploy resource allocation necessarily independent of ourselves, right? So we did touch base almost immediately with the ESFA on-call individual. So while they weren't operational, they were aware of what was going on. And at that point, we discussed what they were going to start to work on once they got into the EOC and how we could help. And at that point, they did delegate their authority through their resource mobilization team and ESF8 to the HCC to begin ordering ambulance resources and sending them to Avista. So we used a web-based EM resource to assess what was available, and kind of worked from there, and we're able to provide them with ingress, egress, staging areas, comms, etc., so they could start to move toward the event at that point in time. So I do want to acknowledge that, yes, we did support the resource mobilization process, but that was essentially a delegated authority through ESF8 as they were working to operationalize themselves. And I see in the Q&A, Cody asked about what would you recommend. So obviously coalitions, they live or die on relationships. So that's key. The way that we have done that historically in the North Central region is fully integrate our HCC into really anything and everything that's happening within the region. So when Mark and Chris talk about the exercise with the EMS liaison role, we were present at that. We worked closely with Chris on other evacuation efforts. And so we really insert ourselves into any training and exercise and preparedness events. We also lead some of those. But we really tie into all of those, because our idea is, if we're going to be a support mechanism, we need to have the diverse relationships. We need to understand the processes that happen on a day-to-day and an emergency event, so that when we get a call that says we need ambulances and ESF says go ahead and do so, we know the platforms, the people, the communications modalities, etc., to go ahead and step in and to help fill that role. So we really just integrated into everything that happens within our region. We're lucky that we have the ability to do that. And so that builds the relationships, but it also builds an understanding of the processes, protocols, and platforms that may be in play when things like this are occurring. So Mark, back over to you.
So just to tie it back into the time frame, we're probably, I don't know, 10 patients into this evacuation process, and in some ways simply overwhelmed by the needs that were occurring in the hospital, what's occurring outside of the hospital, trying to get ambulances to the hospital itself, and also trying to remain, at least for myself, situationally aware of the fire growth and the location of the fire as it pertained to the hospital, because as the really the sort of the fire command structure at the hospital, it was on me to ensure that the protection of the hospital was occurring. So at about that same time, I can't remember who said it, but somebody within the hospital reported that they were seeing flames outside of the ICU windows. And as Chris had alluded to earlier, one of our major concerns was a single broken window becomes essentially an avenue for a flow path into the hospital of burning embers, of significant smoke, and the chance for a legitimate structure fire to occur, even in a fire-resistant building. And that's not even to mention the roof. If the roof had enough ember land on top of it in the right places, we could have had a structure fire as well. So as all of these things are occurring, we're having development of fire around the hospital itself. And in one of those initial maps, I pointed out the Coal Creek neighborhood. The fire had already jumped the highway and was quickly approaching the hospital itself. The liquid oxygen tanks were on that side of the building, on the west side of the building. And you can see here, these are images taken from the emergency department of fire wrapping around the building itself, cutting off our ingress and egress, and making it quite complicated to not only manage what's occurring in the hospital, but trying to keep track of patients leaving the hospital. And one of the comical things that seemed to occur was every time we felt like, okay, somebody else has shown up and we have an additional resource here to assist with patient tracking or assist with a development of a fire operational plan, that person would get pulled to have to go do something else because we were stretched just so thin. You think about this one singular hospital in a very large community of a ton of fire. Everybody needed help. Resources were being requested everywhere, and trying to identify a prioritization process for that was difficult. So the next two slides are videos. I'm hoping they're gonna play for you just to give you an idea of what occurred just to the north of the hospital, and I'll talk about that if these things do play. So those are all homes of the Coal Creek neighborhood. The fire had wrapped around that north side of the building and had engulfed one singular home, we identified the need for fire resources and started calling for those resources from the same alternate county dispatch center. We were fortunate enough to bring in fire resources to be able to at least protect the hospital itself. But as it became aware that we had a decent protection of the hospital, our ingress and egress became the major concern, as did the fact that this entire neighborhood of 150 plus homes was starting to go. Let's see if we can, oh, sorry. Here's one more just for another idea. And unfortunately, despite the valiant effort of all of the firefighters that were in that neighborhood trying to protect it, really the biggest thing that came out of it was the fact that they were able to protect the hospital itself. That entire neighborhood, all 150 homes were destroyed in that section, let alone what else was adjacent to it. So this will just jump forward and not keep playing. But just a destructive process of the neighborhoods around it and that ingress and egress. So during all of this, trying to stay in communication with the ICS structure of the fire, requesting resources where possible, trying to keep PJ updated on what was occurring, and then also trying to identify what ambulances are coming to our location and what path are they taking. If they're coming from the north, they're never going to get here. They're going to be stopped. If they're coming from the south, they're probably going to have to drive through some form of fire. And we just had very little recognition of which ambulances were coming. We knew that some were coming and we had a decent idea of what radio channel they may key up on. But one of the very frustrating things that day was every time I would key up my radio, it would be busy. And then I would wait and then get a clear signal and then try again and it's busy again. And I'm hearing calls for priority traffic from the neighborhood from my firefighters. I'm hearing calls from the ambulances trying to identify a staging area, which didn't exist. There wasn't enough ambulances backing up to even identify a staging area. They were coming immediately to the emergency department, loading up a patient and leaving right away. So just a very complex situation of a hospital evacuation that then became even more complex as the fire really impacted where we were.
And Mark, if I could jump in really quick, just to reiterate a point you made about who is coming and how, that is one of the lessons learned that we have, amongst this group, but especially on our side, since we were doing an amount of that resource ordering, is a better way to track and let those on scene know who was coming. We were able to monitor that a little bit through the radio, so we were keyed up to the same channel Mark was using, and so we could hear different agencies, checking in, etc. But we needed a better method to inform those on the scene of what was coming to them and how they were coming. We were giving them that information, but then there was definitely a gap. So just as we're going through this and highlighting lessons learned, a better tracking mechanism and communication mechanism. I was texting Mark, who was on the way, but a million people were texting Mark and his phone was blowing up and Chris was extremely busy. So, that wasn't the most efficient modality. So that's something else we're going to be looking at moving forward.
This is an image of the sort of the aftermath of the burn. And this is what I was talking about. This is the ingress from the north. There was just certainly no way for ambulances to utilize this road to get there. And then from the south, the road is right underneath the fire line there itself too. So it's kind of a difficult hospital to get to on a normal day. And when there's a firestorm, it became very complicated and something that we continually pushed up through the ICS structure of ingress and egress are a concern. So thinking about your own hospital or thinking about your own facility. And one of the things we have not touched on the campus itself was that mental health facility. It was a very different situation. I can't actually remember what their technical census was or what their patient population was that day. But one of the reports I was getting constantly was a concern from the firefighters about what we could do with that facility itself. How do we evacuate this facility? They don't necessarily need ambulances. They need buses, and not like the term ambulance bus, but like an actual bus or some sort of movement capability. And fortunately, the company itself that operates that building was working on that at the same time. Our folks were putting out a fire on their fence that was leading up to their roof line. So the other thing was that trying to shelter them in place for the time being because of their very different status. These are not patients on ventilators. They're not NICU kids that can't tolerate smoke. We just had to balance what's the risk, what's the gain here. If we try to just let everybody out, how are we going to keep track of everyone? Where are they going to go? That building in particular was very complex, and there was a lot of concern about its exposure to fire itself. So I would commend the firefighters that were around that building that did an excellent job of ensuring the protection of it and the ability for those folks to shelter in place before they were able to evacuate towards the end of the Avista evacuation. And on that, it was about 2 hours, I believe. Is that right, Chris? 2 hours from call for evacuation to the point where we got all 30 patients out of Avista.
Yeah, it's 2 hours from trigger to end, and probably about an hour and a half from the first EMS vehicle, because it took about 30 minutes probably to get that first one there from when I made the request. When you made it, it's obviously a little bit shorter, but first EMS vehicle to end of it was about an hour and a half.
As you look at this map and you move kind of the right here, it's a split screen, but to the right of this hospital of Vista is another hospital, Good Samaritan. Good Samaritan is a much larger facility, and at the same times that Avista was trying to manage this evacuation, Good Sam is hearing about this and experiencing their own influx of smoke. The smoke in a 100-mile-an-hour wind does not dissipate vertically. It's getting pushed directly to the east into the air handlers of Good Samaritan Hospital. So we'll talk about that in a second. Chris, was there anything else you wanted to close out on Avista or Michelle before I move on to that? There's the follow-up for how long you guys were closed at the end of it.
Yeah, I mean, we got a lot of questions, but I think we'll try and hit those at the end as we do some lessons learned and questions. So I definitely want to leave time for a lot of these questions.
Sounds good.
And, as Avista was evacuating, we were pushing out information to our state emergency management, state public health, our other hospitals in the region, et cetera. And we were in conversation with Good Sam, and I know we're going to kind of get into this, but going back to what Chris said, we were pushing out what we had, but that situational awareness, even once Good Sam was starting to play around with the idea of evacuating, getting into kind of a pre-evac mode, was still very, very difficult to obtain. So we were trying to fill that information sharing role, but it was still very hard with this type of an event to get solid information out for decision making. So Mark, I'll let you jump into Good Sam.
Yeah, and just as a quick anecdote, as I spoke about all of the members of our community that worked at Avista and the areas that were burned, this is just one small section of neighborhoods that were burned. There are many other areas of very high density homes that were lost, and a lot of Avista employees, I think it was 20, right, Chris, lost homes. So people working that day losing homes.
Yeah, 20 affiliated with the hospital, associates, volunteers, and providers.
So as Avista became essentially an empty building, I drove back by my house really quick, which was just to the north here, right off this area, and I grabbed a few things from the house. I grabbed our 2 cats that were still in the home, and I called PJ and asked, hey, what else needs to be done? Where can I now assist that this has been taken care of? And PJ said, Good Samaritan is evacuating. Please head over there and give us an idea of what you need. So it was almost like this rapid practice of Avista was going to play into this Good Samaritan evacuation. And just in building type, you can see that there's a similarity here. A very big building that's fire resistant again, but being inundated with smoke. And what Good Sam didn't want to do was wait. They didn't want to wait until the fire had encroached on the building like it had in Avista. They didn't want to wait until there was smoke within the ORs where there were people still on the table. So they decided to get every patient out of the hospital. And at the time, the census was 151 patients, I believe, or 153. So a bigger facility, much more complex. And in the same boat, when I pulled up to the hospital and met with their EMS manager, Rob Frakes, actually it was 163 patients. It became a very real, different animal than what was occurring at Avista. And that's literally where I stopped what we were doing, established command, picked a radio channel, and then I called Michelle back and said, this one's different, this one's bigger, I need help. So Michelle, can you jump in there?
Yeah, absolutely. Thanks, Mark. So yeah, I spoke with Mark. I had been in contact with Good Samaritan. I'd been in contact. The EOC was now operational at this point in time. And so I confirmed the numbers that we had been hearing with what Mark was learning on the scene there. And then again, asked what they needed. And so he let me know basically anything you can get because of the size of this evacuation in comparison to Avista. And as Mark mentioned, this one was going to be a bit more strategic, a bit more paced. There was a little bit more order to this because the time impact was much less than what was seen at Avista. The movement or of the fire around that facility was much more rapid. So we, as I mentioned, had launched an EM resource. It's basically an incident management resource assessment tool that we use. It's web-based. A lot of states use it. You guys are probably familiar. We had closed down the Avista request. We relaunched a new request for Good Samaritan. And basically did a rinse and repeat of what we did for Good Sam, starting to call into agencies and dispatch centers, etc. We also first made contact with those entities who were in the process of sending rigs or buses, medic units to Avista when that got terminated. So we made contact with them and said, hey, if you're able to continue en route, switch up, go to Good Sam, and redirect them there. There was another staging location for assets at a nearby mall. So we touched base with command there and said, hey, whatever has been sent there as far as medic units, can you push them out to Good Sam and just start getting them lined up by the ED. So it was again a little bit more time. We did touch base back in with the EOC to confirm that this wasn't already a process happening within the Emergency Operations Center. Gave them a brief update. They said go ahead and proceed, and so we started sending units that way. I will mention that as this was playing out, we were then on the phone. It was like dominoes. We were then on the phone with a nearby community hospital, a UC Health facility in Broomfield, actually, that was also talking about pre-evac plans. Luckily, they have some internal resources, some medical transport resources just to the north and in the northeast region. And so they were starting to deploy some of those down to that Broomfield hospital so that the community assets, public and private, who were at Good Sam could remain there and they wouldn't be taking from that facility. Luckily, the Broomfield hospital did not need to evacuate, but they were on the cusp and already taking action to prepare their patients for potential movement.
I think this image does a lot of things justice, but what it shows is a much more efficient method of moving patients. We have one of our captains there doing patient tracking, checking in every ambulance that comes into the facility, identifying a destination that's been set up, and then providing that tracking for which patient in which ambulance to which hospital. And this was just because of the time frame that we had. We had more resources at this point. Nighttime was beginning to fall. So we started this process. It became fairly smooth. And one of the things that I think we always talk about in EMS is when you have an MCI or you have a lot of patients that you have to move, generally speaking, it's difficult to get enough ambulances to move all of those patients right away, right when you need them. Well, during this, let me see if I can snap back to this last picture here. We ended up with 40, it was greater than 40 ambulances staged in the parking lot of Good Samaritan Hospital. And this is a result of bed shortages, of staffing shortages, of COVID. We have the resources to move patients. We have this very large hospital that needs to evacuate, and we simply don't have the destinations to send them. So the diligent work inside of the hospital, of the administration, of the physicians in the emergency department, of the ICU docs, of everybody trying to coordinate where are these patients going to go was a pretty remarkable feat. And one of the things that Dr. Jason Rosa would typically talk about here is their role as our EMS physicians. So EMS trained or fellowship trained, board certified EMS physicians, our medical directors respond to this hospital, and they were able to go in and actually round the ICU, see every patient, and help the ICU doc recognize that maybe this patient doesn't need critical care, maybe they can go by ALS. Or, well, maybe this can go by ALS with a ventilator because 2 of our agencies have ventilators. So utilizing that knowledge base of our not only EM physicians, but EMS physicians really played a significant role in being able to move patients quicker. But even with all that said, we ended up with destinations that didn't work out. We had ambulances that were sent to hospitals that had the resources reportedly available, and then were turned away upon arrival because they didn't have a ventilator, they didn't have the nursing staff, and we had to redirect them to a different facility. But the benefits of having those docs, our docs on scene there that night, were remarkable. And had they been at Vista, I think we would have benefited in the same way, but they genuinely could not get to the hospital because of a lack of lights and sirens on a car and the fire itself. So a pretty interesting benefit to have that worked out fairly well. And then just so we have time for questions here, Chris, you want to talk about Vista?
Yeah, just real quickly. One of the questions talked about what utilities were impacted. We did lose water because they had to start pumping surface water from a reservoir lake into the system to maintain firefighting efforts. So we were on a boil water advisory, and that during the recovery was a pretty significant struggle to one, start cleaning everything. We couldn't really do a lot with cleaning and water until the water was clean. So that took a few days. Air handlers, all these HEPA filters, all the other filters in the air handlers all had to be changed out. You're talking, I think it was close to 200 filters, and hospitals just don't have a complete change of filters sitting there. So we had to borrow, beg, and steal from other hospitals, which we were lucky to be able to do. So the recovery piece was a huge incident in and of itself. And someone asked about an after action being out there. I will share the after action once it's kind of gone through all its pieces. It's pretty much done. We're working on improvement plan stuff now, but I'll get it out to you guys so you can all look at it.
Good Samaritan, on the other hand, we did something that was really beneficial. We took a timeout every once in a while during this process and reassess the situation. As nighttime falls, the wind typically dies down, and that's what happened that night. In fact, it actually started to snow. So as we were going through the night, we had reached 55 patients in evacuation from Good Samaritan. And in coordination with the ICS structure for the fire, the hospital administration staff, and through the emergency department itself, we determined that we did not need to move any more patients. So all of the critical care patients had been moved, the ICU, the NICU, the emergency department, and much of the floor had been moved as well, just the typical floor patients. But there were still upwards of 100 patients in the hospital. So they were able to remain in the hospital due to the quality of air improving, and then they actually repopulated beginning that next day. But an interesting fact was, Vista's closed for 19 days. Good Samaritans closed for basically the night, but all of that staff had been moved to other facilities to assist with the patients. And when they reopened the next day, they were understaffed, and it made it quite difficult to be just a working hospital as they were waiting to repopulate with not only patients, but staff as well. And what do you guys think? We've talked about all of the lessons learned, I think, through here. It may be beneficial just to take questions at this point.
Mark, do you want to talk quickly about with Good Sam when you guys took that kind of time out? I think it maybe have been right before that, but the decision or the acknowledgement that you could use non-medical transport, because I think that while it terminated shortly after that, just that acknowledgement and the ability to move a little bit more efficiently is worth sharing.
Yeah, towards the end of the evening, when we had all of the critical care patients moved, it became a reality that not every patient remaining in the hospital needed a bus, an ambulance per se. So we use the term bus in Colorado, and it's going to get confusing here. So not every patient remaining in the hospital needed an ambulance or a medic unit. They needed to be moved. And because of that, I called Michelle and said, I don't know how you're going to do this, and I'm not sure what our resources are right now, but I think I need some form of city bus or a school bus. Can you work on that for me? And without anybody else really in my, Rolodex to be able to call, so much of this fell back on communicating with Michelle for these kind of unique requests.
And that was another, I wanted to bring that up for the acknowledgement of non-medical transport and how that can be utilized, but also to say that that's where we as the HCC tied back into the EOC. So we called into ESF8 and said, do you have any school buses? They said, yes, they're currently supporting an evacuation of a residential care facility. here's their number for their transport coordinator, touch base with them, and they were able to divert resources once that was completed with the residential care and start to move toward Good Sam. So again, that HCC support role, right? It was a little bit of a liaison at some point as well, saying here's what's needed on scene. Can we call into the EOC? Do they have that ready, available? Can we make contact with it and then support the coordination of that asset getting on scene for what they needed for the evacuation?
And I think we can, Chris, did you have something? I'm sorry.
No, I've been trying to just type some of these answers to some of these questions that were kind of straightforward, but yeah, I think some of them in here we didn't hit on yet, but I think we definitely should. So
That's great.
I
I'll
guess-
just wrap it up with a very big thank you to all the names that were on here and everybody else that was involved in this. The relationships it took ahead of time to make this successful have really come to light following this. So I think more than anything, and at least my biggest takeaway from this, is if you're not integrating from an EMS standpoint with your hospitals, or if your hospital is not integrating with the EMS in the community, there's a big miss there. And it can feel very much like, as an EMS provider, we have all of this encompassed and we can handle these situations. When it came down to it that day, I needed every bit of help that I could get and then some. So please take the time to interact with your EMS agencies and the community hospitals to at least have these conversations before something like this occurs.
So I'm just going to kind of go down a couple of these things here that I haven't necessarily answered by typing the answer. Coordinate the evacuations. Did you have a point-to-point agreements, mental health population? So in the ED, we did have one psych patient that we immediately requested law enforcement support for, to come and pick that patient up and move them. Boulder County Sheriff did a great job. We asked for one, law enforcement person to come take this, and they responded with about a dozen deputies that actually did a secondary search of the hospital, basically going room to room. As a firefighter, we have a primary search and a secondary search. A secondary is usually done by a different set of eyes. So they did a secondary search of the hospital, which was a great help having that resource when they showed up. No real point-to-point agreements. Again, this is that relationship. Because I actually was the EM at St. Anthony North, it was me communicating with my chief nursing officer over here what we could take. And I think Mark or Michelle may have hit on this week, and I'm sure everybody knows, between Christmas and New Year's, not a lot of people are at work. It's that questionable time frame. And within Avista, we had very few leaders. There was actually only 2 directors in the facility, no executives. The decision to evacuate was made by myself and my director of facilities, who was acting as the hospital incident commander. At St. Anthony's North, there was 1 executive and a few directors. So we were operating with very limited resources in both facilities. And Mark kind of touched on it from a patient tracking, from an incident command. We just did not have the resources in-house to do the things that, again, we had in our plans and we assumed we could do. We just didn't have them. I mean, a lot of it was truly shooting from the hip. So that point-to-point agreement piece there.
Hey, Chris, really quick, since you were kind of talking about staff, I know this is a separate event, but NCAR fire that happened, 2 weeks ago, and the wireless emergency alert that went out, and the impact on staff. Do you want to talk at all about kind of what you're doing with your staff and how that kind of prompted subsequent action to support the staff? I think it's an interesting point to share.
So, yeah, I mean, the fire itself, we did have, some significant impact in the community and our staff. And what was the NCAR fire 2 weeks ago now? We had another fire up in Boulder near the NCAR facility, a research facility. After the Marshall fire, Boulder County instituted more wireless emergency alerts, and the NCAR fire occurred. And the way those WEAs got pushed out, people at Avista actually received evacuation notices from the NCAR fire. So that triggered a lot more problems. So one, we have to now educate on how those WEAs work, and where's that single source of information coming from. It's not necessarily come within the hospital. It's not coming from those WEAs. So we need that situational awareness. If you're not using Twitter, I mean, that is, following, your local public safety. Those are the places where that information is coming from. And, we found the evac zones on Boulder Police Department Twitter page for the NCAR fire. And I was able to push those to my CEO, who was able to push those down to the staff at the hospital. So we're getting better at that communication, situational awareness, and pushing that information, that accurate information, out in a better manner. That kind of what you're hitting on there, Michelle?
Yeah, absolutely.
Okay.
And we're, as an HCC, we're working on supporting kind of the aggregation of open source information that's coming out during these events, in that first 180 to better support our hospitals. So, some of the work that we're doing now to support that SA component actually came out of NCAR, and the information that was coming out and the concern that arose. So that's kind of, as Chris has mentioned a few different times, one of the big lessons learned, and something we're working with our hospitals to try to set up a better process for first 180 information sharing in NSA.
ICS patient tracking, so no electronic ICS and no patient tracking. We use EM track within the system, within the region here. I've trained on it an awful lot. Part of the exercise, some of the stuff Michelle mentioned, we developed a process for how to use patient tracking, and our patient registration people in the hospital have owned that responsibility, taken on the ownership of that task. But again, we didn't have the resources to actually do it that day. It was kind of a struggle, and if we're looking at, can we build that better? We actually have a workshop coming up this Friday here in the region around patient tracking. So yeah, it's something we could definitely improve. It's an improvement we need to do, but as Mark will say, and most EMS people say, it's a struggle to go from EMS to the hospital, but we have to start at some place. So I think the hospital's taken on that ownership to start that.
There's one question about what was the point at which we would evacuate the hospital, just sort of post haste? When would we actually just pull the trigger and say we have to leave now? There's too much danger. And it wasn't necessarily something we were talking about in a game plan while we were standing there. I think it was taking it bit by bit, piece by piece. We're seeing a neighborhood on fire to the north of us, 150 homes torching off, and there's fire wrapping around the building. I think all of us were at a point of, yeah, this is pretty bad. But as long as the building is not actively burning down, we're going to continue doing it in the way that we can. And our pace did seem to pick up quite a bit. The one thing I did think about while we were doing it was, if we just had to leave the facility itself without a destination, without any other planning, and we just put people in ambulances and drove off property until we got to somewhere safe, that was probably the next option. But we were fortunate enough that we didn't get there, and that some of the slow decision making in the right ways did allow for ingress and egress to be protected. So had we tried to just say, wow, our ingress is blocked, our egress is blocked, and not recognize that, yeah, that grass is going to burn, and then we're going to be okay. So there was some excellent decision making by some of the fire commanders that were out there.
And just to, again, Mark and Chris made a great decision, I think pretty early on in Avista evacuation, that it was going to be quicker to one, keep patients close by because those were Centura facilities, but also those medic units could quickly return back to Avista, as opposed to sending them 45 minutes down the highway and they are out of service or are unable to come back in a short amount of time. They made the decision to keep them close by because it was faster to get those to come back and make another cycle, make another run, than it was to get new resources in. So I think that was a great call on their part, and helped with the rapid need to push that hospital out.
Couple questions about reunification and contacting families. Not a lot of that was occurring during the evacuation. Once all the patients got to North, a lot of leadership started showing up at St. Anthony's North. We moved our hospital command center from Avista, the people that we had, over to North, and the Centura organization took on a lot of notification of family members and really did a really good job with telling them where they were, that they were safe, and everything that had happened, and dealing with it that way. So they did a really good job with that. Let's see here. I think we talked about the Hicks a little bit, that it really was non-existent that day. So kind of redundant communications around patient tracking. We don't have a lot of good redundant around patient tracking. I mean, someone had asked about FirstNet and I typed in an answer. I use FirstNet now in my hospitals, and I actually have the hotspots through FirstNet, so we can utilize it if our primary networks do go down. So we have some redundancy built in with FirstNet, but as far as mesh networks, man, I'd love to use mesh networks. I think it's something cool, and that might be a couple years down the road we look at for the region. I think there's an extreme utility and value in mesh networks, but we're just not there yet with that. POV transports, it was talked about. And I was kind of putting a kibosh on it as much as I possibly could, trying to squash that down, saying, no, I don't want to necessarily get to that point unless we actually have to, like Mark had said, you know, if this is a emergent evacuation, like more emergent than it was, yeah, we'd have basically done what we needed to do, but we still had a good process of moving people by EMS and doing it in a fairly controlled manner. And I just wanted to keep it going that way. Mark, would you agree with that?
Yeah, 100%. We did have one patient go by Uber from Good Samaritan. It was a discharge to a long-term care facility. A Good Samaritan called Uber, put the patient in the Uber with a staff member from the hospital, and ensure the patient arrived at the destination as they should, and all well-being was taken care of, and that went well. So kind of a unique one-off there, but it went well.
Yeah. Anytime did you determine a time that all individuals must leave for safety? So staff members, we basically once we were done moving patients, and I'll say what the staff members did was pretty amazing. They took it upon their own. I don't think anybody directed them to do this, but they started moving all the patients on the second floor down to the first floor. With the amount of smoke in the building, it was a very real possibility our fire alarm system would have activated, which means we can't use elevators. So then we would have been evacuating with med sleds. So they actually took the time to move them while we still had use of elevators, which was a good job in leaning forward. Once we were done with kind of patient movement, either internally and externally, people were gathered in the lobby. We briefed them, and they did get a little bit of an escort with law enforcement safely out of the area. One of the ways they left was actually through a field, driving past cows, but they were able to make it out of the hospital safely.
And I know the EV batteries at Tesla were a consideration. I don't know that, I don't have a count on how many actual Tesla vehicles burned, but it was certainly discussed at the level of Louisville's fire chief and Mountain View's. I didn't hear anything beyond that, though. They are tearing that building down today as we speak.
Did you add a point of ingress and egress from the hospital? So I don't know if you could have, I don't know if Mark, if you want to try and pull that up real quick and go to the kind of close in view of a vista. There's actually a dirt road that goes to the north of the psych hospital that, like 3-4 years ago, we actually wanted to build into a second point of ingress and egress. It would have been nice to have, but in all reality, it wouldn't have helped in this fire because that was the area being burned over as well. From the opposite side of the hospital, there's a golf course, and there's just no way to actually bring another point in. So you'll see just to the north of the psych hospital there's a road that leads to kind of, it looks like a dirt road. Again, that whole area was burned and really wouldn't have helped with our ingress and egress. And there's no other way from the north or the west to actually get a road in there. So it will, I mean, it's obviously been out there publicly now. Vista is actually looking to move down the road about a mile or two in the next 5-7 years is what it looks like. So obviously we're looking at better ways to do some of this stuff after this fire. Going through any other questions here. Mark, Michelle, you guys see anything in here that I haven't touched on yet?
We did utilize, we have ambulances, medic units that are in reserve status that we did upstaff that day. There was a ton of, my fire department was 100% called back. So we had everybody that could respond back did, and then staffed units and assisted with relief of those that were on the fire line to begin with that evening. So a lot of folks were pretty tired by the end of the night, and upstaffing of other reserve units is only as good as the equipment that you have to do so. It's easy when you're swapping out two ambulances, one's going out of service, one's coming in, but to have all of the reserve equipment for multiple ambulances is quite costly and difficult to manage. So easy when you have a fleet program for a major city department, but a little bit more difficult for a medium-sized department.
There's a number of questions and comments in there about patient tracking, and as Chris mentioned, we're as a region working on the finalization of a patient tracking unification plan. Hopefully this Friday we'll get some final determinations made for that. We use EM Track. That's what we have as a system as part of that Juvare platform with EM Resource. So I see there's some discussions about Salamander and tags and those types of things. So Chris, I don't know if you used any, I don't believe so, but any tagging process within yours, but as part of the development of this plan and the use of EM Track, that is a component we are looking at doing. Now, again, that comes secondary to patient safety, life safety efforts. So
Medical Reserve Corps, Boulder County does have a very strong Medical Reserve Corps group. The speed at which this happened, it was just impossible to get any of that stood up and utilized as a resource. Again, those assumptions, if this was a fairly little bit slower of an evac, we probably could have utilized some of it, but again, this was just so fast. I think Blake just put it in there. Handle staff patient communication, intent to evacuate. Failure on myself and my hospital incident commander. Once the decision to evacuate was made, we realized that we had to start doing stuff, and we quickly realized that we did not do a good job of communicating the process of how we wanted to do it. So we've addressed that through a policy and a plan. I will say the one thing that I have changed pretty significantly is, I get HICS. I understand HICS. I've been an ICS guy my whole life, from fire, EMS, and everything. Sometimes the use of hospital incident command itself, it can be a little bit of a struggle. I'm changing a lot of my training away from simple box checking, job action sheets, and other things to pure critical decision making, crisis decision making, how to use situational awareness, how to make decisions with very limited information. Our hospital leadership, they're used to looking at things from a work group or a committee and getting all the information and then making a decision. You just don't get that luxury in these things. I mean, it was making decisions that we had to live with within the next 2 minutes, and trying to change the mindset of leadership to think that way is kind of where I'm taking my training now, if that makes sense. And it's still a work in process of how I'm going to do that. So it's just something I really realized that, a lot of the things that we do really wouldn't have helped us this day. I mean, we did a presentation, somebody asked about compliance. Yes, compliance is nice from a training standpoint, but it really doesn't help a lot during an incident. And you've got to have that institutional knowledge and that situational awareness and that experience to make those quick decisions. Having Mark there, someone who's got that experience, be able to help us make quick critical decisions, is something we really need to be striving towards.
And there is quite the appetite in the region and probably the state of formalizing this EMS liaison role. So while it was conceptual in nature prior to this event, we are moving forward with the folks you see presenting today, as well as other key players, to really build out a solid concept of operations, job action sheets, et cetera, for this liaison role for future events. Because while it was somewhat ad hoc in this event, there were so many lessons learned, and I think the benefits of that role being on scene at the hospital can absolutely be shown effective, in an all hazards approach. So I know we didn't get too deep into that liaison component and how new it was, but that is something we're looking to formalize here and make available to other incidents as we move forward.
One question was about were staff leaving to take care of the homes problematic? No. In fact, our two directors that were in the hospital that day, they initially kind of rock, paper, scissors to see who's going to take incident command, but they quickly realized that one of them, his house was in the evacuation area. So, he took off to deal with it. We're going to do what we need to do, with them leaving. It definitely was, they need to get home and take care of what they need to take care of. So didn't look at that as a problem at all.
We had firefighters in the same way that had homes that were clearly within the path of destruction and stayed selflessly because that's what they were going to do. And I watched numerous nurses leave their vehicle at a Vista just to jump on an ambulance to ride with their patient to a different hospital. Just a remarkable showing of selflessness across the whole area.
And to that point, it's something we really didn't touch on. I mean, we transferred 20 patients to St. Anthony North. I'm sorry, 25 patients to St. Anthony North, which was about 20 to 25% of their capacity. So it was a significant surge event for them as well. With that came the staff. So a lot of the other issues they dealt with at North was badge access. Nobody had access to the med rooms from a Vista. Nobody had access to anything else. Where are the restrooms, food, a lot of these kind of things popped up that we just never really kind of thought of. Yeah, we're moving not just patients, but 20 nurses to a new hospital, and how do we deal with that process? So again, all things we're now looking at from a evacuation type standpoint. I hope we're
cleanup, Chris. The reopening process.
I mean, yeah, we kind of touched on it, but yeah, the reopening, the water was a struggle. Air handling, we had significant particulate counts in the hospital. We had 200 HEPA air filters throughout the hospital scrubbing the air. That was a little bit of a concern. If y'all work in hospitals and you ever want to know how much stuff you have in a hospital, move it out of every room into the hallway and then invite the fire marshals in and watch them have a quick heart attack. Because it was amazing. We ended up, purging a lot of stuff. It was a good winter cleaning. I think if we could have weighed the hospital afterwards, it would probably be about 20,000 pounds lighter just from stuff we ended up throwing away. But having to re-sterilize and basically triaging supplies, what can we keep, what needs to be re-sterilized, what needs to be reordered. Our supply chain crew did a fantastic job of determining what do we need to get back in working order.
I see the question there about setting up ESF2 comms, within the EOC. So, and Chris and Mark jump in, but for a Vistas event, again, they were pretty much done with their efforts by the time the EOC was open and operational and could really step in and support that. So that was done very much on the fly with picking channels that could could support the interoperability of the different agencies. With Good Sam, I think, because Mark had already designated a channel, he had set that up through a Vista, and it was simply just a rinse and repeat of that event. There wasn't much support from the EOC on the comm side that was needed at that point in time. I don't know if you guys had anything else around comms, but it was activated within the Boulder Office of Disaster Management. But again, the hospital side was already pretty structured due to a Vista by the time they were able to provide some support.
All right, folks, we're at the top of the hour. So I want to thank the panelists wholeheartedly from our 7HR team. This has been an awesome webinar. The feedback we've been getting in the chat plus email has been outstanding. So I really appreciate your time and your efforts for for spending this sharing this experience with us. As a reminder to everyone, there is a CME information in the chat. Also, and I'm going to share my screen so you can see the activity codes. You should get an email from our CME folks within a few days. And then the webinar will be posted on our webpage within 3 to 5 business days. Normally we do have a monthly webinar, and we're advertised on our Facebook and LinkedIn. So please don't hesitate to share and like us there. With that said, we're going to close out the webinar. Once again, thank you very much for the panelists and for being here today.
Thank you guys, appreciate it.
Thank you.
Thank you, everyone.